So we're going to talk about what you need to know about sleep disturbances in neuro-ophthalmology. The most prevalent sleep disturbance that we deal with in neuro-ophthalmology is obstructive sleep apnea. And it's exactly what it says. It's apnea. A means not, nia means knee, but P-N-E-A, breathe. It occurs in sleep, and it's obstructed because the airway obstructs. So in obstructive sleep apnea, we've got problems related to the apnea, we've got problems related to the sleep, and we've got problems related to the obstruction. And so in neuro-ophthalmology, the things that we need to worry about with obstructive sleep apnea are disc edema. And when it's unilateral, the most common cause of acute unilateral loss of vision with disc edema in someone who has obstructive sleep apnea is actually non-arteritic anterior ischemic optic neuropathy, a stroke in the optic nerve from small vessel disease. And that is related to the apnea because you have hypoxia, and that can lead to ischemia. However, if it's bilateral disc edema, the thing we're worried about is not so much NaION, even though it could still be NaION. The thing we're worried about there is idiopathic intracranial hypertension. So that's increased intracranial pressure for no reason. So they have an MRI and an MR venogram, it's negative, and they have increased ICP. This increased ICP also could be related to the apnea, but not from the hypoxia that causes ischemia, from the hypercapnia from poor exchange. This hypercapnia leads to vasodilation, and under the Monroe-Kelly doctrine, increases the blood flow from vasodilation and can lead to increased intracranial pressure. The other thing that's important is the obstruction, forced expiratory effort against a closed glottis. It sounds like this. That causes increased intracranial pressure from the increased intrathoracic pressure that's necessary to generate the expiratory effort to open the closed glottis. Both of those, the obstruction and the hypercapnia, can lead to increased intracranial pressure and is a risk factor for idiopathic intracranial hypertension, especially when the demographic is not our typical demographic, males instead of females. And of course, it's going to occur in sleep, and that's a problem because the pressures might only be elevated in sleep. And so a daytime lumbar puncture might be normal. And so you might say, well, they don't have IIH. When they really have IIH, it's just at night when they're sleeping. The other thing we need to know about is narcolepsy. Now, narcolepsy is similar to obstructive sleep apnea because they have excessive daytime somnolence, but as opposed to obstructive sleep apnea, you're having the problems anytime, including the daytime. So they might have what looks like a syncopal episode, they just fall asleep. We do a sleep study on that person to look for the REM disturbance and the sleep latency time. And they might have associated HLA predisposition in the DR2 and the DQW1. These HLI haplotypes are associated with narcolepsy. And of course, you can't have any other DSM-5 diagnosis. Narcolepsy comes to neuro-op as neuromyelitis optica. So the combination of disc edema or optic neuropathy with a sleep disturbance, you should pick obstructive sleep apnea because that's way more common. However, if they meet diagnostic criteria for narcolepsy, you're going to order the aquaporin 4, which is the antibody for NMO. And the aquaporin 4 regions are the optic nerve and the chiasm, but also the hypothalamus, where the hypocretin and the narcolepsy is coming from. So you need to know a little bit about obstructive sleep apnea, narcolepsy, and sleep disturbance in neuro-ophthalmology.